The topic of my today's lecture is acute appendicitis. The objectives of today's lecture are that by the end of the lecture, the students of final year MBBS will be able to understand the surgical anatomy of appendix, and they will be able to give a management plan for the cases of acute appendicitis in 4 out of 5 cases. Now, regarding the anatomy of appendix. Appendix arises as a blind outpouching from lower end of appendix at the site where three tenuculi merge, near the ileocecal junction. Now, regarding the positions of appendix, the position of appendix is never constant. The commonest position of appendix is retrocecal, which is present in 74% of cases. The second commonest position of appendix is pelvic, which is present in 22% cases. Rest of the positions are pre-ileal, post-ileal, and subcecal, which are present in hardly 1 to 2% of the patients. Now, what is acute appendicitis? Acute appendicitis is acute inflammation of appendix. Its peak incidence occurs in teens and early 20s. Now, what causes acute appendicitis to occur? The cause of acute appendicitis is largely unknown, but few people say that it occurs due to obstruction of the lumen. This obstruction may take place due to presence of a fecolith tumor or due to worm infestation. Now, when acute appendicitis occurs, patients may present with central abdominal pain that may later lead to the right iliac fossa. This pain may be associated with nausea, vomiting, loss of appetite, low grade fever. This may also be associated with constipation or diarrhea, especially if the appendix is pelvic in position, then patient may present with diarrhea. Patient may also complain of abdominal bloating. Now, when we examine these patients, patients generally have tachycardia. If the child, if the patient is a child, then patient may have coated tongue. If we ask the patient to cough, patient complains of pain in right iliac fossa. This is known as a positive cough sign. When we palpate them in right iliac fossa, they have pain in the right iliac fossa. This is known as tenderness. And if we lift hand while palpation, they feel more pain. This is known as rebound tenderness. Similarly, while palpation of the abdomen in the left lower quadrant, if we lift hand gently, patient feels pain in the right lower quadrant. This is known as positive Rovsing sign. Why it happens is because when we lift hand from the left lower quadrant, peritoneum and appendix move, and inflamed appendix touches the peritoneum of the right lower quadrant and causes pain. This is suggestive of acute appendicitis. There's another sign which shows a retrocecal appendix. If we are suspecting a retrocecal appendix, we test it by Swas sign. We hyperextend the hip joint of the patient. If patient feels pain on hyperextension of hip joint, it means that the appendix is retrocecal because the retrocecal appendix lies over the Swas muscle. And on hyperextension of the hip joint, the Swas muscle is irritated and patient feels more pain. Similarly, if we are expecting the appendix to be in pelvic position, then we flex the hip joint and internally rotate it. The pelvic appendix lies over the obturator internus. By this maneuver, the pelvic appendix irritates obturator internus and the pain of the patient increases. Thus shows the positive obturator sign. The diagnosis of acute appendicitis is mostly clinical, based on history and physical examination of the patient. And it is consolidated by the certain investigations, which includes CBC. In CBC, we look for total leukocyte count, which is increased in acute appendicitis. We go for urinalysis to rule out urinary tract infection. In females of childbearing age, we go for ultrasound abdomen to rule out gynecological pathologies like ruptured ovarian cyst, ruptured ectopic pregnancy. Certain cases where there is diagnostic difficulty, in only in those cases CT scan of abdomen is needed for focused CT scan of appendix. Otherwise, CT scan abdomen is not routinely used for diagnosis of acute appendicitis. When a case of acute appendicitis has been diagnosed, then treatment is surgical. The approach can be open or laparoscopic. When open approach is chosen, then a small incision is made in right iliac fossa and open appendectomy is done. For laparoscopic approach, three small incisions are made through which three ports are inserted and laparoscopic appendectomy is done. Laparoscopic appendectomy is now gold standard if facilities of laparoscopic surgery are available in the center. So, to summarize the case, acute appendicitis is acute inflammation of appendix. And when diagnosed, acute appendicitis should be treated by appendicectomy, and appendicectomy should be treated by laparoscopic approach as a gold standard if facilities of laparoscopic surgery are available in the center. Thank you very much.